Hello to my dear colleagues from all the MENA region. First of all, I would like to thank the organizing committee for inviting me to this important conference in order to share this presentation with you. And secondly, I would like to accept my apology for not a live presentation because of difficulties in access to internet which nowadays happened in my country. The topic of my presentation is treatment of those with type 2 diabetes and comorbidities, ASCVD and CKD. After discovery of insulin about 10 years ago, we just think about control of blood glucose in diabetes. But we learned from so many studies that diabetes is not just blood glucose. This is a study that published in Lancet 2010, and it showed us patients with type 2 diabetes have twice the risk of CV disease than normal population. World Health Organization reported in 2014 that between 50 to 80% of deaths in people with diabetes are because of cardiovascular disease. CDC also reported between 2010 to 2014, diabetics be hospitalized due to the heart attack 1.8 times and due to the stroke 1.8 times more than non-diabetics. There was an article in JAMA 2050 that showed us life expectancy is reduced roughly 12 years in people with diabetes and previous MI. And this is a very nice slide from Diabetes Atlas 2019, considering many cross-sectional and prospective studies. It shows us in people with diabetes, the prevalence of any cardiovascular disease is 32%. Coronary heart disease is 21%, MI 10%, and stroke 7.6%. And also diabetes has the greater risk for any cardiovascular disease. The risk of coronary heart disease is 160%. Ischemic heart disease is 127%. Hemorrhagic stroke is 56%, and CV death roughly 132%. So it shows us we have to more take care of heart than glucose. But how we can do this? Let's go to different studies which have done in 5 recent decades. This is the list of different historical important cardiovascular outcome trials in type 2 diabetes, focused on intensive versus conventional glycemic control. The most historic one is UGDP in 1917. It shows neither insulin nor oral agent provided greater protection against CV complications than diet only. Tolbutamide and fenfluramine, the only available OHA at that time, were associated with higher mortality. UKPD has showed us intensive glycemic control in type 2 diabetes was associated with a reduction in microvascular complication, but there was no statistically significant effect on microvascular disease and mortality. Advanced in 2009, showed us intensive glycemic control targeting hemoglobin A1C below 6.5% improved microvascular outcomes but had no impact on macrovascular outcomes, but increased hospitalization and severe hypoglycemia were potential complications of intensive control. Accord shows us increased mortality in intensive glycemic group. VADT showed us minimal impact in both macro and macrovascular disease. 10-year follow-up of UKPDS and VADT from 2008 to 2015 showed us there was a CV benefit with intensive glycemic therapy at 10 years follow-up, but no reduction in CV mortality. So these historical studies showed us intensive glucose control does not any impact on CV outcomes, but even harm regarding hypoglycemia and mortality. But as you know better than me, because of lack of time, I couldn't go through details. So many studies with WIC and with EMPA-REG and LEADER showed us new hypoglycemic agent, SGL2 inhibitors, and GLP-1 receptor agonists had a clear role in CV outcomes. And this is a very nice slide that shows us meta-analysis of GLP-1 receptor agonist cardiovascular outcome trials, significant reduction in all CV events, 40% reduction in MACE, 30% in CV deaths, 10% in fatal or non-fatal MI, 17% in fatal and non-fatal stroke, 11% for heart failure hospitalization. As you see in this slide, SGL2 inhibitors have beneficial effect on MACE, heart failure, and progression of DKD. GLP-1 receptor agonists have beneficial effect on MACE, CKD, but neutral effect in heart failure. So the ADA guideline changed after declaration of ESD-ADA consensus in ESD meeting in Berlin in 2018. Before 2019, the guideline focused on glucose, and it was completely glucose-centric guideline. But after that time, the focus was on heart more than glucose, and it changed to a cardiocentric guideline. The other matter is individualization. You know better than me that not all diabetics are the same, and they have individual characteristics. This is a very good example of difference of type 2 diabetes. Let's first go to the red column, which used to be named as lean type 2 diabetes. The pathophysiology in this group is only beta cell dysfunction. So in this group, we have to think glucose-centric, because there is no morbidity rather than hyperglycemia. And we can use potent hypoglycemic agents such as GLP-1 receptor agonists, insulin, or sulfonylureas. In the yellow column, the main pathophysiology is obesity, and we have to think weight-centric. But in the gray column, the main pathophysiology is atherosclerosis and inflammation. So we have to think cardiocentric, and use agents can have cardiorenal protection, SGL2 inhibitors, or GLP-1 receptor agonists. But if we consider the population with diabetes, population with obesity, and population with CV disease, you can see they have intersections. I love this slide from ADA guideline in 2022 very much. If we liken diabetes control to this Roman building, prevention of diabetes complication is like the roof of this building. First, we need the foundation, which is diabetes education and lifestyle modification. Then we need 4 columns. In addition to 3 historic columns of glycemic, blood pressure, and lipid management, we need another column, which is agents with proven benefit or cardiorenal protection. But it is a nicer photo from New ESD ADA Consensus 2022. It shows that we need 4 components for prevention of diabetes complication, which includes glycemic management, cardiorenal protection agents, weight management, and cardiovascular risk factor management. This is an ongoing cycle, and we cannot say which one is the first step and which one is more important than the others. This is a table from ADA 2022. It shows us for assessment and treatment plan of type 2 diabetes, we have to investigate for ASCVD complications. And if there is no ASCVD but existence of risk factors, we have to do ASCVD risk assessment and use the ASCVD risk assessment calculator. ASCVD, what does it mean? As you better than me, MI, stroke, any revascularization procedures, TIA, amputation, unstable angina, symptomatic or asymptomatic coronary disease are categorized as ASCVD. But how we can do risk assessment for ASCVD? You can do risk assessment with American College of Cardiology and American Heart Association ASCVD risk calculator. It's generally a useful tool to estimate 10 years risk of first ASCVD event available online, and you can see the address of this site in this slide. But as they mentioned, this calculator does not account for duration of diabetes or presence of diabetes microvascular complications such as albuminuria or retinopathy. This calculator has also an app which you can install it on your mobile phone. There are 14 questions for calculating the 10-year cardiovascular risk. And by answering to this question, you can estimate 10 years risk of the first ASCVD event. As you can see, the question number 9 is about existence of diabetes or not. If the result is below 5, it means there is a low risk for development or cardiovascular disease event in 10 years. Between 5 to 7.5 is borderline risk, 7.5 to 20 moderate risk, and above 20 is high risk. But I have to say, when your answer to question number 9 is yes, the risk certainly is above 5. It means that all diabetes have the risk for CVD complications. There is another risk assessment calculator from European Society Cardiology, and as you can see, there is no risk again in this table. There is also an app available for this system. In this app, you can select the right calculator. And the right risk assessment for type 2 diabetes is advanced risk score. You can enter sex, age, duration of diabetes, which doesn't exist in American app, presence of retinopathy, and also urine albumin creatinine ratio, which doesn't exist in American app again. Then you can calculate the 10-year risk of ASCVD event. But the problem with this system, this app, is just showing fatal events and doesn't show us non-fatal events and heart failure hospitalization. This is the new algorithm for use of glucose-lowering medication in management of type 2 diabetes from ADA-ESD Consensus 2022. Healthy lifestyle behavior, DSMES, SDOH are the first line. Then we have to select the goal: cardiovascular risk reduction, cardiorenal risk reduction, or glycemic and weight management. And the arrows shows us we cannot say which goal is more important than the other goal. We have to think to achieve both goals simultaneously. But if we focus on diabetics with ASCVD or high-risk group, we have to start with SGLT2 inhibitors or GLP-1 receptor agonists as the first line. And if hemoglobin A1C is above the goal, we have to add the other one which we didn't consider for starting step, or we can add TZDs. In people with heart failure, SGLT2 inhibitors should be used because they improve the heart failure and kidney outcomes. And for people with CKD, we have to start with SGLT2 inhibitors or GLP-1 receptor agonists if SGLT2 inhibitors not tolerated or contraindicated. It is for CKD. But as a conclusion, in people with established CKD, GLP-1 receptor agonists with proven benefit should be used to reduce MACE, or SGLT2 inhibitors with proven benefit should be used to reduce MACE and heart failure and improve kidney outcomes. In people without established cardiovascular disease, but with multiple cardiovascular risks, such as age above 55, obesity, hypertension, smoking, dyslipidemia, or albuminuria, GLP-1 receptor agonists with proven benefit could be used to reduce MACE, or SGLT2 inhibitors with proven benefit could be used to reduce MACE and heart failure and improve kidney outcomes. In people with heart failure, CKD, established cardiovascular disease, or multiple risk factors for CVD, the decision to use GLP-1 receptor agonists or SGLT2 inhibitors with proven benefit should be independent of background of use of metformin or baseline hemoglobin A1C should be considered. In people with CKD, SGLT2 inhibitors and GLP-1 receptor agonists reduce the risk of MACE independent of EGFR. In people with CKD, SGLT2 inhibitors also reduce risk of heart failure and kidney outcomes. In people with CKD and EGFR above 20, SGLT2 inhibitor with proven benefit should be initiated to reduce risk of MACE, heart failure, and kidney outcomes. If such a treatment is not tolerated or is contraindicated, GLP-1 receptor agonists with proven CV outcome benefits could be considered. At the end of ADA-ESD consensus recommend this holistic person-centered approach to type 2 diabetes management. The goal of treatment is reduction of complication and increase the quality of life. We have to consider 4 components of care: glycemic management, weight management, cardiovascular risk factor management, and finally cardiorenal protection with selection of right lowering medication. Then we have to consider different principles of care such as DSMES, SDOH, reduction of risk of hypoglycemia, avoid inertia, psychosocial factors, and etc. In glycemic management, we have to choose agents that have adequate efficacy to control hyperglycemia, which may include metformin or combination therapy. Weight management is a very important component because it is not relevant to my presentation. I don't go through details, and I'm sure other speakers will explain it completely. In cardiovascular risk factor reduction, we need screening for risk factors, blood pressure lowering, lipid lowering, and antithrombotic agents, and also smoking cessation. And finally, we have to use special agents for cardiovascular protection. So altogether, we can reach to this slide. So it means that it's very specific and individual for cardiovascular and renal protection in patients with type 2 diabetes. Thank you so much for your kind attention.